talk about what do we mean by public health surveillance. Again, these terms tend to repeat itself fairly often. So when we look at it, it's nothing else but an ongoing systematic collection, analysis, and interpretation of health data. So it's a sequential process, and which is essential for planning, implementation, and evaluation of public health practice, closely integrated with timely dissemination of the information people need to know. And this is taken from the Centers for Disease Control. So when I look at this, it shows a lot of different things that covers, mainly looking from a perspective of an epidemiologist. What would an epidemiologist do as it relates to surveillance? He or she will be involved in planning, implementation, and of course, evaluation of public health practice. And I will further go down and talk about it a little bit more later. But the goal of surveillance is to protect and promote health, to prevent disease, injury, and disability and death, provide information for descriptive epidemiology. Okay? That's a very important part. What kind of survey you do or what kind of surveillance you do, the data becomes amenable to undertake analytic studies from the surveillance program that we have. And largely the information always surrounds or it revolves around the information that we need as it relates to person, place, and time. So further, so depending on the type of study, we can include occupation and sex. We can definitely have to include the place, and of course, time, depending on the time interval you are looking at. Okay? So keep this in mind. This is a universal model of public health. Okay, this is the universal model. We can't really mess around with it too much unless and until you got some novel or brilliant ideas to make it happen. So how does surveillance fit into the public health process? So if we have a problem, say we have an ongoing issue related to measles in school children, so that's a problem. So we start off by doing a surveillance, okay? Now we can either do one of the three types of surveillance, typically active surveillance or passive surveillance, depending on the nature of the condition. Then what do we do next? Once we conduct the surveillance, we then identify the risk factors. What are the causes? Now, in case of an outbreak of measles in school children, we find that there were 2 recently admitted children who had not undergone vaccination. So as a result, the measles spread within the school children between the age groups of 3 and 5. Okay, so after that, what are some of the interventions? Now that you have identified the risk factors, how will you intervene? Okay, and now that you have identified, we will ask some of those students who have come down with measles to stay away from home, stay away from school for a certain number of days till they get a letter from the physician that they are free of infection. So that's the intervention that we would do. That's something that is simple, easy to do, and more importantly, manageable. Next is, how do you implement it? You just overnight cannot rule in and say, you can't come to school. There's a process for it. And more importantly, after that, there's another box that is missing is a follow-up. Follow-up after doing the implementation. Has your implementation really worked? So the missing box here is doing an evaluation of the implementation strategies that you have put in place. Okay, so keep this. This is the virtual model that we use for all public health studies. In fact, it's driven by surveillance. That's the take-home message from this slide is it's all driven based on surveillance. Click on this. Okay, so why do we use public health surveillance? One is to estimate the size of the health problem. How many people are infected in a given population? How many people are healthy? Determine where an illness is occurring geographically in terms of an index case. So when we looked at doing the histograms, we were able to find an index case. So the index case helps us to move forward in order to understand what is the nature of the outbreak that's taking place. Okay. In the process, we understand the natural history of the disease. Okay. This helps us to detect epidemics, especially based on rates. generate hypotheses, monitor changes in infectious agents. For example, if you're continuously monitoring samples during the COVID period when we started seeing a change from the Delta to the Omicron, because we would do public health surveillances in many different settings, either in a hospital or on, in schools or in workplaces, wherever people would submit samples, that would become the source of examining the sample for the different variants of the corona viruses. Okay, detect changes in healthcare practices, triage area prior to ER access in case of an outbreak. You can't expect 500 people lining up in front of the emergency room. So how do you quickly adapt? How do you set up triage centers? You convert a school, a high school, or a middle school, or elementary school, so as you can accommodate in order to identify whether the person actually has the infection or not. If the person has the infection, then a certain different set of steps are put in place, where to place him, where to place her, what kind of treatment we need to follow. Next is facilitate emergency planning. We anticipate there is likely an outbreak going to come because we have seen the disease outbreak taking place in Philadelphia. And within a couple of days, it will move to State College. We very well know it because it's a trade of commerce, right? Whatever people move from Philadelphia to State College, you would expect a small percent of them to be carriers. And if they come into the State College area, most probably they'll infect other people. Okay, so who performs a public health surveillance? It's mainly epidemiologists. So we are the ones who drive the show, but we always need the help of medical professionals such as doctors, nurses, pharmacies, veterinarians, health insurance providers, emergency responders, 911 centers, where you can pick up the phone and dial 911, immediately connected anywhere in the US to the emergency services. Next is public health departments. Local, state, and federal departments are involved in the process. Okay, so how is public health data collected? Now, what I'll probably do is come back to this at a little bit later point in. Anyway, let me finish it since we are here. So one is outbreak reporting. Another is morbidity data collection systems. When we look at outbreak reporting, we have several specific surveillance programs that are already in place. Okay? For example, the influenza surveillance program. The influenza surveillance program is just not looking at people with avian influenza or flu, but we also look for virology. What are the different serotypes? In addition to that, based on outpatient illness surveillance. Then we look at mortality. We tend to see higher rates of mortality in the elderly population that are coming for another condition that come down with flu in the hospital. Hospitalization surveillance, summary of geographic spread of the influenza. We definitely know if there's a large outbreak of avian influenza in California, it will take about 4 days to 5 days before it comes to Pennsylvania. So how do the public health people prepare for it? How do they inform the physicians? How do they inform the school system? How do they inform the public health systems across the state, right from the state, local boards, and the district boards? Right? Another program we have is what we call as the West Nile Surveillance Program. It's again a more comprehensive program where we look for cases of encephalitis. So if there's there are people who are admitted with signs of encephalitis, they become a probable suspect or a possible suspect for West Nile virus, because it's a syndrome. So encephalitis can be caused by many similar viruses, such as the encephalitis, Japanese encephalitis virus, or the West Nile or the St. Louis encephalitis can all cause similar syndromes. But in addition to doing that, we also collect larval and adult mosquitoes. Over a period of time, the Department of Environmental Health actually goes and collects samples of mosquitoes and the larvae. The reason why we do this, we know for sure mosquitoes winterize because we have severe winters. It goes to negative temperatures for about 2 to 3 weeks, but the mosquitoes are able to survive. And they are really able to survive is under the pipes or the sewage systems where the temperature is somewhere close to around 50s and 60s. They stand in they kind of go to hibernate in the upper side of the seaweed system, but they're still carriers of the virus. So we collect pools of mosquitoes from the seaweed system and then examine them for the larval stage. And of course, we do PCR to look for the West Nile virus. Another interesting part that came in was putting in sentinel chicken testing, especially at the human-animal interface, okay, where we're likely to see the changes taking place. We keep chickens there. So chickens don't die of West Nile virus. They get seroconverted. So if they get seroconverted, we go and draw the blood once in every 3 weeks or once in every 2 weeks and look if they have antibodies against West Nile. So if there is antibodies against West Nile, and if it is an active form, we know West Nile is there in that given area. So those are some of the chicken testing. Another is we encourage all owners, if there's a dead crow in the backyard or dead birds in the backyard, is to bag them and take it to a local veterinarian, and he will send it to the public health lab to get it tested for West Nile or any other insect. So you can see when we target a given disease, we look at all the aspects of it, wherever we can do the surveillance and bring that information together in order to have what implementation or what strategies we need to implement in order to control them. Another way surveillance data is collected is using morbidity and mortality data. Okay? For example, death registries. When we go and look at death registries, typically the cause of death is generally mentioned: heart attack or coronary heart disease or encephalitis. But many a times it so happens, how do I put this? If an individual dies and the family members know the coroner in a small town, in a small village, they usually will hesitate to put down the cause of death. So many a times we don't have complete records of COVID-19 in the very early stages because the diagnostics wasn't there. And there was hesitancy of being labeled as a person who passed away because of COVID. So those are some of the issues that we typically tend to see as it relates to mortality rate when it comes to death rates. Another is the medical examiner. Many a times, earlier we used to do postmortems. Whenever we would do the postmortems, would be out of every 10 people who died, we would at least conduct postmortems around between 5 to 7, depending on the coroner. Now we are lucky even if we do one out. So the number of postmortems, unless and until the coroner thinks he suspects something is really wrong and we can't really figure it out, that's how we start using the medical examiner. So the another aspect is morbidity data. Morbidity data is there are many reportable diseases, like every country has a set of reportable diseases, and things like TB, sexually transmitted diseases, hepatitis, they all are reported to the local health department, then to the state, from the state at the federal or the national level. Next is cancer registries. These are some of the databases that are growing in number, largely because it's as being driven by physicians to look at is how best we can utilize this data to address tumors, cancers of different types. Okay? So the cancer registry becomes very important as a part of an ongoing process to address non-infectious diseases such as cancer. Now there is birth registry. How many children were born with some sort of a congenital anomaly, or they had some medical issues at the time of delivery. So all of those details are captured during the birth registry. Now there is hospital discharge. When you discharge, there is a reason why the person was admitted, and when was the person discharged, the length of stay, the duration of stay, the cause of the disease, or comorbidities that coexist along the same time can be collected. Now we do specialized surveys. These are really specialized surveys that are done. One is NHANES, and another is National Health Information Interview Survey. Now the National Health and Nutrition Examine Survey is rather fascinating. So they select 5,000 individuals in certain geographic regions, and there is a semi-truck, a bus that goes to that given place, and they collect everything that's possible on those individuals. in different geographical regions, right from looking at the habits, the risk behaviors, the disease conditions, everything they collect information. So NHANES is a very important survey because a lot of the people from the insurance company use it in order to assess the health of populations. Okay? Another is National Health Interview Survey, where we examine close to 30 to 40,000 people at a given time. This is self-administered interview, so we don't actually go physically in front of the house. And that's a very comprehensive review or process of collecting data. The next one is the National Notifiable Disease Surveillance System, because there are, for example, in the US, we have 60 nationally notifiable infectious diseases, 10 non-notifiable infectious diseases, and most of the information as of today is through the National Electronic Telecommunication System, or as NETS. Okay? So the system is fairly streamlined, but all of these different processes that we do to collect data is based on one single system. So it starts off with the county and the state health departments that seek information from physicians, laboratories, clinics, and community health clinics. For example, standardized collection. How many number of TB cases were confirmed? 1 TB case, 1 HIV, 9 Lyme disease. That is sent to the county and state health department. That data is analyzed using statistical methods, and following which the information is disseminated to the people who need to know. For example, public health officials, just in the sense that they feel that there's likely emergence of a new disease or a disease is coming back in larger numbers. How do public health officials work around? How do the health directors go and obtain funds or resources to address the issue? Next is health policy officials. Do the current health policies put in place are adequate enough? And finally, it is the physicians. The laboratories should know what they are seeing on a regular basis within the given state. So the dissemination is one to the public health officials, another is to the people who provide us with the information. So how is it done? It's typically done through weekly updates, reports, conference seminars, or other means to a variety of people that can benefit from it. Most of the time, earlier would be the fax machine would be running in the doctor's office, saying we found 5 cases of that, 10 cases of this. You need to stockpile on these vaccines. You need to have these antibiotics ready at hand. So that's the information that comes from the public health officials to the physicians who are working. And this, and by the way, I'm talking about physicians. We follow the same pattern for animal diseases. It'll be veterinarians, laboratories, and people in local communities. They have a list of diseases that they have to report. They report it to the Department of Agriculture. So within the Department of Agriculture, we have the state veterinarian. So the state veterinarian's office has epidemiologists who analyze the data and then share it with the Secretary of Agriculture and other health officials, and also share it with the local CDC within the state of Pennsylvania. And accordingly, we make decisions. For example, we see there is an increase in the tick population. Hunting season is coming. We are seeing an increased tick population. We send out advisory notices to all of the hunters and their associations to say we are seeing increased tick population. So take adequate precautions before you go and do hunting. Okay? So that's how we connect with the loops of the information that we tend to generate. So one is, for example, increased frequency of confirmed Lyme disease. We are seeing more and more Lyme disease cases. Why is it occurring? Where is it occurring? Hepatitis A outbreak. We find that there are an increase in the number of food trucks that are coming around during festival times and selling food. As a result, are we seeing an increase because of these food trucks increasing hepatitis A? Increased reported cases of rhinitis in 5 years. Are we seeing an increased rhinovirus because of the combination of allergies to the pollen plus the rhinovirus impinging the allergic system and causing more severe issues? Right? So When was the HEPA filter changed in the EMS? One of the questions that we typically tend to ask is, when was the HEPA filter changed in the emergency system? If we are seeing recurrent infections coming in within a hospital, the first thing we suspect is the HEPA filter system. So keep that in mind. Even though we have safeguards, we see nosocomial infections keep running in the hospital. So you go and check, hey, when did you change the filters? When did you change the cooling water in the cooling towers? Okay. So this is the similar model that we use for public health evaluation. I will not go much into it. So we'll kind of go into the different kinds of surveillance, or different types of surveillance. The first kind of surveillance is what we call as passive surveillance. So this is the typical model that we generally follow. I'm sure this is almost in all over the place, but I do not know in India how actively the local health department solicits information from physicians, hospitals, the public, and the lab. So I'm totally ignorant about it. So generally the process starts with the lab, hospital, physicians, and public health people providing information to the local health department. So you can see the arrows. They're all moving away from the lab, hospital, physician, and public health to the local health department. Then you can see from the local health department, the information is shared with the state health department. And you can see the arrow is bidirectional here in this stage. And the same thing, the state utilizes the information and shares it with CDC, who then analyzes it at an aggregate level for the whole nation at a given point in time. Again, you can see the arrows are bidirectional. So this is what we would call as passive surveillance. We are intaking the information, but we are not actually going and looking for it. Okay? And especially passive surveillance is done for those diseases that are supposed to be reported. Many a times you may also see unusual cases being reported, or things that the physician doesn't understand, or the local hospital doesn't understand. They reach out to the local health department for guidance and solution on it. So regular reporting of disease data by all institutions that see patients or test specimens are a part of the reporting network. And this is called as passive surveillance. Passive surveillance relies on the cooperation of laboratories, physicians, or other healthcare providers regularly report cases of diseases to the local and state health department based, again, I'm coming back to the same standard case definition. Okay? It should meet the case definition for that particular disease. Example, a doctor's office reports 2 cases of measles. Even 1 case of measles is reported because it's a reportable disease, right? A nursing home reports an unusual number of older patients with unexplained rashes. How do we address that? They do not have the answer or the ways to diagnose it any further, so they reach out to the local health department. So, sorry, let me go back previous slide. So these are the reportable diseases in Pennsylvania. So every state has its own list. Okay? For example, in Pennsylvania, we have a few more diseases than other states have. And the same may happen with Ohio or with West Virginia or Virginia. They may have diseases that we don't see in Pennsylvania. For example, we tend to see a lot of issues related to, in Pennsylvania, we tend to see on an occasion E. coli 57H7 infections that gets diagnosed a little later. So therefore, we have included that as a part of our reporting system. So let's move on and talk about active surveillance. We finished passive surveillance. We'll talk about active surveillance. So the active surveillance process, you can look at the arrows here, okay? It is the local health department and the state health department that initiates the process. When local and state health departments actively search for information by contacting healthcare providers, laboratories, schools, nursing homes, and workplaces in order to see, are we missing something? Is there something that's going on that we need to be aware of? For example, if there is an outbreak of tuberculosis in a nursing home, and as a result, many people have moved out of the nursing home, whereas as these individuals, where have these individuals gone? How do we trace them back? How do we pull them back into the system so that we have a better control on the disease? So if you can see, most of the process is initiated by the local health department, the state, and the state health department. And once they collect the information, they analyze it, and then share it with the CDC. Example, during a cluster investigation of E. coli 0787, epidemiologists might call pediatric nephrologists. Why pediatric nephrologists? What does E. coli 5787 do? Because it causes hemolytic urinary syndrome, HUS. So that's one of the reasons why we specifically focus on pediatric nephrologists. Okay, and in the state to find out whether clinician has treated any patients with hemolytic urinary syndrome, which could result from an infection from this organism. So we go to the extra mile. We do the extra mile to pick up whatever likely cases of hemolytic urinary syndrome caused by E. coli 0787 have occurred and we might have missed in the process. Okay? So active surveillance achieves more complete and accurate reporting than passive surveillance because we are going behind something. So I think you guys sat for my lecture, and some of you, did you sit for my lecture? Oh, okay, so it's going to be a little bit of the repeat. What I'm really looking at is digital epidemiology is going to go big. And if at all you want to experiment, I would highly encourage you to start doing syndromic surveillance. So how do I film this? Syndromic surveillance is an example of digital epidemiology. And again, when we look at the definition, very similar to surveillance, but there's only one change in the word. The ongoing systematic collection, analysis, interpretation, and application of real-time indicators. These are real-time indicators for the disease that would allow the detection before public health authorities would otherwise inform. Now, when we look at the process of epidemiology, what we would apply initially during the origins of epidemiology, going back to John Snow's time, it was traditional epidemiological surveys, very traditional, going house to house, knocking on the door, collecting the information. Then over a period of time, when the revolution, digital revolution started somewhere way back in the 1980s, 1990s, 2000, we started looking at a shift. Rather than collecting the information on the paper, we would have tablets. We would have other means of collecting the information, right? Now we have reached a point in time, modernized epidemiology and survey with big data and AI is going to come on us. Whether we are ready or not, it's going to get dumped on us. So let us be ready for it in the process. In order to do that, let's try and understand a little bit of what do we mean by indicators of disease. I use the term syndrome. It's a syndrome. That means a collection of different clinical signs put together as a cluster of observations. So indicators are clinical signs that we can characterize into syndromes, but not a specific diagnosis. Example, cough, sore throat, fatigue, fever, influenza like these. Archana may come tomorrow and say, I think it's listeria. So people are, Rahul may come and tell me it's listeria. So when we look at influenza like flu-like syndromes are seen with many other diseases. So we need to be cognizant of the fact it's a syndrome. So how do we utilize this syndrome? Okay. There are many syndromes that are under surveillance. One is gastroenteritis. Another is influenza-like illness, meningitis, encephalitis, rash or fever, botulinum or hemorrhagic colitis. Now with that, I was able to pick up from ProMed, way back. I think this was somewhere in 2019. I think in 2019, Rome had reported a case of an outbreak of salmonella in Tiswadi. So I picked up that paper and I kind of expanded this. So let's take a look at and use this as an example here. December 19th, overflow of a swine waste from containment facilities on 3 farms were detected following heavy winter cyclone that generally occurs in that area from December 16th to 19th. The effluent spill was adjacent to tomato and cantaloupe growing regions of the taluka. The spill was restricted to agricultural lands. On December 21st, the environmental assessment ruled out contamination of the natural lake with the swine. So that was the first thing. Is it gone into the water system? So there was a confirmation saying that yes, the spill occurred, but did not enter the water system. But it so happens 10 days later, what happens? Using whole genome sequencing, they were able to identify Salmonella infantis in patients, in swine effluent tanks, and from cantaloupes. How did this whole process take place? So December 25th is a very important part of festival, especially in places like Goa, with a high ethnic population of Christians. So what happened? When we go back in time, the Tiswadi State Public Health Department declared an outbreak rather quickly. So on January, they were supposed to declare this on January 2nd based on the data, but they were able to do it as early as December 29th. So this is rather fascinating. What really happened? Okay, when we look at the whole process between December 23rd and June 1st, I'm sorry, that should be January 1st, they were collecting data as to how many sales were taking place in terms of in local grocery stores. On December 3rd, they found there was a huge rush behind cakes, mutton, chicken, hot dogs, cantaloupes, fresh fruits, beer, liquor, paper plates. 40% rise in demand in the last 24 months. Wow, there is a spike in food. One would expect just around the time when there is a festival coming around. But when we following the Christmas holiday between December 26th and 29th, they were still monitoring the process. What did they find? They found excessive internet chatter. For example, on Google search, diarrhea, vomiting, headache. So people are Googling it to find out what the hell is going on. So through real process, you can capture those data points. On the Twitter, I'm out of commission. I'm sitting on the toilet. Instagram, you start seeing a lot of pictures of toilets. So these kind of indicate there's some sort of a syndrome going on. We're not really sure what it is. Now, to add to the process, they also started seeing many people are not attending schools or not attending work. Okay, there was an increase in the people who were going to the emergency room. And more importantly, when they started talking to the local retailers, they were seeing a lot of anti-diarrheals being sold off the counter. So when you connect the dots between sale of food, internet chatter, absenteeism, ER visits, and over-the-counter sales of anti-diarrheals, what happens? If you're able to collect all of this data, crunch it, and have the right kind of algorithm, if you've written, should allow you to predict an outbreak at least 3 to 4 days ahead of time, rather than when it's going to hit you. The reason being, it helps the public health officials if they're smart enough to prepare for the likely onset of the increase in the number of cases that are likely to come later, 3 to 4 days later on, when the disease actually peaks, right? The outbreak really peaks. So that's the whole process of syndromic surveillance. So, for example, you are tasked with creating a syndromic surveillance for gastroenteric disease in Pennsylvania. What kind of real-time data will you need to set up the syndromic surveillance? So we do internet searches that can be done by public. We can collect that information, over-the-counter sale of antidiarrheals, ER visits, grocery sales of selected items, and we start pulling all this information together. The process is very simple, over and excess. For example, if you suspect foods of high risk, okay, eggs, meat, milk or contaminated vegetables, which you think are green leaf vegetables, if the sale of any given day is, say, let's take cantaloupes. The grocery store is selling about 20 to 25 cantaloupes per bush. What we call as they're selling 20 to 25 cantaloupes every day. But all of a sudden you start seeing an increase of 60 to 70. Understandable. Or you see an excess of sale of a product. You make a note of those things. Same thing. You look at number of combined searches when you take what people are looking for as it relates to person, place, and time. You can be able to collect that. Next is over the sale counters. You start seeing over an excess of sale of medications on the counter. ER visits increased on the 4th, 7th, and the 10th on those times. And then what do we see? July 4th and July 4th, we see a huge number of sale of food products, water lemons, burgers, and the salads and pasta, hot dogs and pasta, right? So if we are able to write an algorithm that is able to track the upper and the lower levels of the sale of products over the counter in several different locations, if it crosses the upper targets in all of those categories, we know something different is happening. Okay? It's like setting the threshold, lower level and upper level. And that's the whole beauty of syndromic surveillance is where do you set the lower and upper levels? If you set the upper level too very high, you're most likely to miss the syndromic surveillance. If you set the upper level a little lower, you're likely to catch a lot of false negatives. So again, it is through experience how we set the bells and whistles in the syndromic surveillance to give us the right indication at a given point in time. So you can see there is a trend that we tend to see when we do combined internet searches, over the counter, ER visits, and grocery sales. So why do syndromic surveillance? Early detection of clusters in naturally occurring outbreaks or a bioterrorism. So the whole concept of syndromic surveillance just didn't develop instantaneously. It is because of the bioterrorism event that took place in 2001 in the US, where the letters were seeded with anthrax spores. And that went all the way to the Congress. So many of the congressmen had their letters laced with anthrax spores. So it became a major issue. And they said, how can we avert this? So that's where the concept of syndromic surveillance did really emerge. And University of Pittsburgh is one of the leaders in doing syndromic surveillance. In fact, they have a full section or a department and an exclusive website as to how to construct a syndromic surveillance program. So they can walk you through it. Okay? So what, and more importantly, is the purpose in the event of a bioterrorism event. So bioterrorism event generally are to create a scare amongst the people rather than kill the people. That is the general mindset of people who are deranged in those processes. Is largely to prevent, to create a kind of change in the society. So, but the focus of public health officials is to minimize the mortality and morbidity if you are able to detect the event of bioterrorism. Okay. And also it will help us characterize the magnitude, the rate of spread, the effective control measures. For example, outbreak of anthrax that we found that was spread through letters from many different states. What did we do? We identified those individuals, and then we provided them with 6 weeks of doxycycline. With every week, somebody from the health department calling on them and checking. And if they feel even the slightest difference, there would be an ambulance that would drive up in front. So we were well prepared, but syndromic surveillance really took a very different turn after the bioterrorism. It's a quick form of investigation. You don't have to invest resources, especially syndromic surveillance. You don't have to send people out on the field. You are getting the information right into your office at that point in time. Okay? And detection of unexplained deaths. Why are we seeing unusual deaths occurring? Is there something that we can associate, and syndromic surveillance may be able to help us? So again, the gain of 2 days is at least minimum. That means your syndromic surveillance is working. If it is 4 days, if it is 5 days, even better. But anything less than 2 days is not working. So we can run simulation models. You can run several different simulation models based on your input of data that's coming from several sources. And if the simulation is working the way it's supposed to work, and it gives you 3 to 4 days lead time, you have a syndromic surveillance in place. So what are some of the limitations? Inadequate specificity, false alarms. As I mentioned to you, setting the upper and lower limits, if we don't set them properly, we may get false negatives and false positives creep into the data set. Inadequate sensitivity, failure to detect outbreaks or bioterrorism events. Outbreak is too small even to detect. Okay? Population disperses after exposure and cluster is not evident. So this, our experience with using digital phones to track an outbreak. So we applied this concept in Mali using the World WHO's recommended standards. Is we engaged a local the largest telephone company in Mali, and at any given time, close to 60 to 70% of the Mali population is on the move, and all they have is cell phones. So through the cell phones, we were able to track when they come to the village, to the main city, close to on a Friday or a Saturday to do the shopping for their groceries and other stuff, clothes and other things, and then they go back to their villages. Right? So that is a high intensity time. So we track their phones. Where are their phones moving? Were they present in the city at that given point in time? And what is the volume of population that came in? And what is the volume of population that went out to different places? So then we are able to keep a track of the likelihood of the disease moving from one given area to other given areas. Okay? So those are some of the ways we can utilize syndromic surveillances, especially when the population disperses after exposure and the cluster is not evident. For us, very locally, it's in a football game. In a football game, you have 100,000 people sitting in a stadium, and there is an event that takes place. We actually do not know where these people went after the football game. Yes, we can track them through the ticket sales and other things, but those are some of the events. If a bioterrorism event occurs, these are some of the what we call as the hotspots that are typically tend to be targeted. It is costly initially to set it up. If it is running well, great. Another is staff expertise. You require somebody who is able to manage the algorithm, somebody is able to compress the data, and then an epidemiologist should be able to come and connect the dots between these observations to make a decision. So what are some of the elements of a good surveillance system? Let's say Rupesh becomes the director of health. And he says, I want to give everybody a hard task here. So let's come up with a good surveillance system. So these are some of the things that Rupesh should be able to think about. First is simplicity. You don't require a massive formula to go through. It should be simple, easy to use, right? The structure of the surveillance should be simple. It should have ease of operation. It should be flexible, depending on how you can use it, because okay, next is data quality. How complete is the data? If you are missing points, virtually you're not able to utilize that. You can utilize some portion of it, but really in the big data analytics sets, if the data complete rate is not there, it becomes very difficult. Another is acceptability, willingness to report reporting entities, sensitivity and specificity. That's where we talk about the case definition, positive and negative predictive values, representativeness of the target population at given time, timeliness, and more importantly, stability, reliability, and availability of the sources of information. So with that much watched video, let me see if I can pull this up. Okay, so we are done with surveillance. You want a 5-minute break?
Hello?
Yes.
Huh?
Let's learn public health. Let's learn public health. It's the beautiful videos, very good videos. And India, and it's from an Australian YouTube channel. YouTube, but it's they've done some excellent videos. Hey, you want to take a 5-minute break and come back? You want to announce? We'll take a 5-minute break.
There is a instructions for online participants. We'll be having 5 minutes break and we'll start the next session immediately after that, after 5 minutes. Thank you.
Yeah, if it is there, sure. Yeah.
Yes.
No, no. We do. It's all due.
They're asking you.
No, we send eyes. They do. For example, I'm looking for I identified certain pneumonia, commutation, and it's a report of it. Then I send that isolate to the public. They will see. No, they do. It's a compulsory. It's a part of the product. What do you do? The reason why we have shifted over all those, like to Soon as, say, for example, you're in touch, send you the isolate, put it in the fridge. Then we start seeing your code. They put all of them on a secret. Invariably isolated stuff. And when we but that there's a trend, when there's a trend like put up all those isolated secret. I can see yes, that's my instrument, but there are instruments that can go 120 of them at once. Why do one isolated? Does that help? It's okay. So it's now becoming standard. We slowly do what's the other. Yeah, so the reclaims CD for the big top. We don't do six by two. Get something like that. Share the data, but I can't share the everything. Share the picture.
So, good morning, all participants, online as well as offline. So, after 5 minutes break, again, uh, we'll start the next topic, that is investigating an outbreak. So, I request Dr. Bhushan sir to continue the next topic. Thank you.
And we'll talk about how to investigate a disease outbreak. Okay. So when we talk about investigating a disease outbreak, there's a certain procedure and a process we follow in order to do that. So in this particular lecture, I will discuss the reasons to investigate a possible outbreak, describe the different steps that we utilize for conducting disease outbreak investigations. We'll describe some of the methodological approaches in order to conduct an outbreak investigation. We'll apply the three main principles of descriptive epidemiology: person, place, and time. We'll understand the role of epidemiology in disease outbreak investigations. And to start off with, what is the whole purpose of doing an investigation? The whole purpose is to stop an outbreak. That's the primary reason. Okay, ensure public health. That's the sole focus, and more importantly, prevent the spread of the disease. The next is to prevent future outbreaks. From the lessons we have learned, can we go and prevent future outbreaks? So if you go back and see, we are not good at it. We had the SARS outbreak in 2003, and then we had another COVID outbreak in 2019. We were miserable. I mean, some countries did well, but some countries were an absolute disaster because they did not really take the lessons learned from the SARS outbreak in 2003. And the countries that did well, where the outbreak took place, was only one country, and that was South Korea to begin with. And some regions of Southeast Asia that tend to do much better as compared to the other parts of the world is because they had encountered a situation very similar to COVID-19 some 15 years or 16 years ago. Okay? So that's the whole purpose. Next is improve surveillance and outbreak investigation. So how are outbreaks usually recognized? It's usually through an astute observation. It's largely through observation of a single event or a cluster of events by a clinician or a laboratory personnel. I'm working in the state public health lab, and I'm seeing submissions of strep throat swabs coming in over and over again from many different hospitals and locations. So what does that tell me? It tells me I need to watch out. I need to keep a lookout for streptococcus-related strep throat infections in a given area. Next is report of one or more patients that come in to tell us that there is something unusual going on here. Another is routine surveillance activity. So we may pick up an outbreak while doing a routine surveillance process. And what are some of the examples that on a day-to-day basis a public health department receives? 6 cases received in the emergency room 3 days post happy hour at Tubby's. So somebody had a party where there was a happy hour. So I don't need to explain to you folks what's happy hour. You buy one drink and you get the other at half the price. So during that time, many of the students usually tend to go during happy hours. And what did they find? 3 days later. So 6 cases of ER at happy hour in Tubby's, that's a restaurant. And what was the lab diagnosis? Salmonella. Another thing that we tend to get involved is 14 parakeets with psittacosis from a single dealer. Psittacosis is a reportable disease, right? Next is school children sick after visiting a goat farm. You're from the city, the school takes you on a trip to a goat farm, you all get excited, and the goat farmer gets excited and gives you raw milk to drink from these goats. And then you come home and you fall sick 3 or 4 days later, right? Because you're naive, you don't have immunity to those pathogens, and being in the vulnerable age, you tend to fall sick. Right? Last one is 2 cases of measles. So when we do, what do we do? Usual scenario when we do an outbreak investigation. For example, unexpected event, 25 high school teens with salmonella, we need to investigate quickly. There are pressures from parents, schools, township to find an answer. Why did these children get sick? Multiple agencies get involved. Local, county, state health departments get involved. There's a media spotlight, especially salmonella in state college can be a big media issue. Next is the work that is carried out in the field. How did we go and investigate that outbreak? Okay? Those are some of the things we as administrators or people sitting behind the desk have to be aware of, that there's a sense of urgency. We need to respect the process that is taking place. We need to inform those individuals who are affected by it. And we need to do it in a more systematic way of addressing these issues. So what we call this as systematic approach. So let me share with you an outbreak of an investigation where I was involved. This dates back to October 2019. So as an epidemiologist, you're assigned to a county, say let's say a Latur district. It's like you're assigned to Berks County. County is very similar to a district, okay? To investigate Campylobacter gastroenteritis. So you're sent there, and where is your office? Your office is in the local health department. So from the state office, you go to the local health, they give you an office to sit, and then you start collecting the data. What did you find? October 19th, there was a farm family of different age groups, all the way from 2 years, all the way to 65 years of age, all located in Berks County. And what's their history? They're farmers. They grow wheat, corn, barley, soybeans, and they don't do any dairy, but they purchase raw milk from a neighbor who has the permit to sell raw milk. So in the US, especially in Pennsylvania, you can sell raw milk, but there are certain stringent conditions you need to follow in order to produce and sell raw milk. Okay, and these people went to the neighbor who sells raw milk and purchased milk. And what was the diagnosis? After one incubation period, they found 4 members of the family were admitted to the hospital with severe gastroenteritis, and the lab report says gastroenteritis. 2 days later, 22nd, we find this to be at the level of a gas station. The owner of a gas station purchases, again, raw milk from a neighbor, comes down with gastroenteritis. October 22nd, the following next day, you find there are workers on a dairy farm who collect milk and prepare quasi fresco. What is quasi fresco? No idea. It is fresh cheese, Mexican fresh cheese, similar to paneer. It's a very popular item. They produce it in the morning, and by evening they consume it. So what is the issue with making paneer and quasi fresco if it is contaminated with a pathogen? Guys, good people here, the answer should be like this. It's raw milk, but it's contaminated. But when you make paneer, what happens? Or when you make quasi fresco, you concentrate the pathogen because it has an affinity to adhere to protein materials. It adheres to casein. So when you precipitate it, you make a nice paneer fully loaded with Campylobacter, ready to be delivered. Okay? So you need to look at the food matrix of the food. Some of the food matrices actually support or also allow the pathogen to survive. So we need to recognize the nature of the food matrix in order to make these decisions. So here we find something pretty consistent. There's something to do with raw milk. There's something to buying a raw milk from a farm. And what we are seeing here is it's all Campylobacter jejuni. And it is affecting a variety of age individuals from different ages, just not the elderly or the young one, it's across the spectrum.
Hello.
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 Oh, 1 second. Want me to continue? Or? Okay, so when we look at how do we conduct an outbreak investigation, we typically tend to follow these 10 steps. Okay? It's not that one step after another step we do. We can do multiple steps at the same time. But ultimately, the last part is communication of findings. So the first thing is to confirm the existence of the outbreak. Also, simultaneously, you can verify the diagnosis, right? And then if you have time, additional time, you can prepare for the field work because you need to go interview people, collect samples, bring it back to the lab, and do further analysis. So let's start off with the first one, confirmation of an existing outbreak. So what do we do? How do we confirm an existing outbreak? The first step is compare the numbers to what is expected by person, place, and time. So we have two set of indicators. Now, the place is State College, Football Illness. In January of 2018, there were 15 cases across the year. In the month of January 2018, there were 15 cases. But in January of 2019, there were 61 cases. So it becomes question, why are we seeing this a threefold jump or a fourfold jump in numbers caused by gastroenteritis? Okay, so that initiates a query. Next step is to verify the diagnosis. Ensure proper diagnosis has been made. Be sure that the lab has not made an error in it. Many times we run into it sometimes. Okay? Verify clinical symptoms. Rule out similar or unrelated conditions. Review medical records. Interview as many people as possible that are associated or not associated with the outbreak. Some outbreaks may not have a confirmed etiology. So you go to do when you are initiated, you see the number of cases rising, but you still are unable to find what's causing the disease. But it is still possible to verify and investigate the outbreak. So you're not supposed to stop there. You need to continue, right? So we continue further. We add 4 more data. Now, instead of Berks County, we are seeing things emerging in Philadelphia. This is different. October 24th, we see another family that's a self-employed computer programmer who drives 45 miles to purchase raw milk. And what happens? Everybody in the family is sick. The lab report says Campylobacter. Then what happens in October 24th becomes even more interesting. It's a new immigrant family. They've immigrated recently from another country. Okay? They operate an ethnic restaurant. They operate a restaurant that sells their native food. So they purchased 20 gallons of raw milk for a special order of cheesecake for a birthday party. However, there's no history of illness in that family because they use all the milk to make the cheesecake. October 26th, 19 attendees of the birthday party. Again, in Philadelphia, cheesecake, hot dogs, salads, everything, name it. 11 of the 19 admitted to the hospital with severe gastroenteritis on October 29th. The lab report says Campylobacter jejuni. So the epidemiologist is able to kind of say, well, this is just not restricted to Berks County. This is moving out. It is much bigger than just the district itself. It's not in Philadelphia district. So these are some of the clues, and what we call this as is preparing a line listing. He creates, I would encourage you to go and open up the software called as Epidemiology 7. And there are more later versions that you may have. So go to the CDC website and download Epidemiology. That's the best software you can ever use. I love it. You can develop questionnaires. It will save your questionnaires. It will allow you to beta test the questionnaires. It can do GIS mapping for you, putting the zip codes and tell the location to create maps for you. So look at Epidemiology 7. In fact, I can teach Epidemiology 7 for 3 days continuously back to back. But that's not the purpose here. So coming to the process, Epidemiology 7 is a wonderful tool, especially if you're looking into doing a disease outbreak. It can be a class exercise. You can give it to the students to work with it. So this kind of information is collated. The next is to prepare for field work. So investigation, what do you need? You require sample questionnaires. So usually, for example, here, this refers to gastroenteritis. CDC has already created standard questionnaires to investigate gastroenteritis. It's a standard form. So, and that's available through Epi-7. You can download the software, and all that you do is enter the data on a tablet in front of the patient. You can do that. Laboratory supplies, if you're collecting milk samples, food samples left in refrigerators, or environmental samples, you need to collect the right kind of equipment to collect samples. Next is, what is the plan of action? It should not be haphazard. I see this number here. I see that number there. It's not. It's a logical process. How do you go and start the investigation? Is it worthwhile enough to split it up into groups? Or is it worthwhile to go as a single group to all of those cases and talk to them? Generally, what do? Is we break up into groups of two. One is the person who actually records the information. The other person asks the questions. So in the process, we tend to get a more complete information in the process. Next is management, operational issues, team composition and role of each. Why is it so important about team composition when you're doing a field investigation? Anyone? Any ideas? Any thoughts? Why is the team composition important? Let's become a little bit more specific. Say you're an epidemiology intelligence officer. CDC puts you on a plane and you land up in Mali to investigate an outbreak of measles. You're from CDC. What are you going to do in Mali? You'll contact the local health department. The first and the foremost is I'm going to get a person who speaks different dialects. It's very important. Although I have my question in English, and by the time I land, somebody will have translated for me in their local dialects. But it's the person who is aware of the local logistics is extremely important for me to carry out the investigation. So it depends on the team. What kind of team do you have initially in order to help with you to achieve your objectives? Next is communications. How do you communicate? Some people may be reluctant to share. Whether you're willing to, or what are your approaches to do that? Next is where to go and who to meet. Our experience working in Africa is I just can't go into a village and start collecting data. Even if I see a chicken and I want to talk to the owner, I usually will not. I will locate and say, where is the headman for the village? Or what we call is the party of the village. So we would go to the headman of the village, convince him why we are here. And then if he sends out the word, yes, these people are allowed to collect the data, then we have a freer access. People tend to be more open to answering questions in the process. So that becomes very important as to where to go and whom to meet. It's just not you enter the village, you're the boss, you start doing things. That doesn't happen. You got to be very, very careful, especially in an international setting. How do you operate? And next is, it's a three-pronged approach. One is you need to do an epidemiologic investigation, which by now you are all experts, laboratory testing, and then of course, environmental testing if environment is a part of the process. So this is what we call as line listing. We look into EpiInfo data, to pull out the data. The first thing that will come up is line listing. Case number one. Here, why we put them as case number one? Because we would not like to have personal identifiers in the process. So case number one, when was the onset? What were the clinical signs? What was the laboratory data? What are the demographics? Now, the information that we had collected earlier is in the background. We don't use that, but allows us to refine our observations. Okay? Now, to tabulate preliminary information in cases such as demographic information, tests, and exposures, to rapidly characterize the outbreak in terms of person, place, and time. For example, on October 19, 35 of 61 cases traveled to Nicaragua in 2018 to determine symptoms and parameters of the case definition. as the investigation processes, the line listing will often evolve into an outbreak database. Can you use this to construct a histogram? Yes. This is the whole purpose. Usually, if you go to AP Info 7, once you have a sufficient number of data points, you say histo. It will create histogram. Okay? You don't really have to manipulate any of that, but you have to describe what are the columns that you need as a form of an input to create your histograms. Okay, next is construct a working outbreak case definition. Again, come back to case definition. We don't know what's causing the infection, so we keep the case definition broader in the sense. Okay? Simple objective criteria where we collect clinical information, time, person, place, develop a case definition based on symptoms or laboratory results, affected population, location, and time. Initially, we tend to keep it broad in the process, making it more sensitive versus having it narrower, where we tend to be more specific. So, and then we categorize the outcomes as either confirmed, probable, or suspect. So, in terms of sensitivity, when we develop the case definition, if the case definition is very sensitive, it tends to pick up it's more sensitive. We tend to pick up fewer false negatives. Now, in the other way, when we look at it, there's a danger of many false positives. Okay, so when we look at the other way around, in terms of when we increase the specificity, we have fewer false positives, but we have more of missing cases. So there's a trade-off. Where do you draw the fine line so as to you don't add in false cases and don't forget to add true cases into the process? Okay. So next is find the cases systematic. Either you can go through the process of active surveillance that we did, contact medical providers, and what are the strategies? What are the strategies can you use to find cases? Let's say, forget this particular case. If I were to ask you to think outside the box, how would you do it? For example, let me throw out the question, smallpox. Smallpox has re-emerged in India. Where do you think you will look for people? Local instincts. Now let's go around the table. Yes, Bhaskar. Children, school children. Okay. Anybody? Who's thinking? Yes, local ancestors. Schools. Okay. Anything else? So, where do you think the most active population transfers takes place? Railway stations, bus stops. That's the spot. You will keep observers located in these places to observe any bus that's coming in and leaving. Anybody who has the telltale signs of smallpox. What is the other place? You look at the temple. You look at the Shitla Devi temple. Put somebody in front. Any family who comes to pray, you follow them back and say, "Tell me more," right? So those are some innovative ways how you can expand your other strategies. Another strategy would be is to have local volunteers who will be able to supply the information. So how you develop the network, because smallpox, if there is an outbreak, it is going to be like how do you say, a stigma. Usually there is a new disease that comes in, people would not like to share it with others or disclose it. So when there is the process of stigma going on, the disease spreads even faster. So we need to break the stigma in order to identify the very early cases. That's what happened with COVID too. People wouldn't be ready to say I've got COVID because they would stay at home, and somebody dies and they're taken away, then we know there was a COVID case. But the stigma over a period of time evaporated or has deformed. The same thing with many cases. Even today, tuberculosis, and other things do bear a certain level of stigma. But that's unfortunate, although the disease is very much curable. Once somebody attaches a stigma to a given disease, then people are reluctant to seek services. And that's the case with smallpox. So we always need to look at innovative ways as to how we can collect information from other sources rather than the traditional ways like schools, hospitals, or other places. So collect data on case patients and then add it to the line listing. So the next step is characterize cases by person, place, and time, who are infected, what the numerator and denominator, who goes into the numerator and who goes into the denominator. What do the cases have in common? As you go back previously and see, the cases in common was consumption of raw milk, sale of raw milk, were the two important factors that resulted in it. Now, in terms of time, we look on the epidemic curve, or in terms of place, we develop a document. And Epidemiology will be able to do that for you. We can draw GIS very accurately if you have the actual location of the house. Generally, using GIS data requires approval from the people that are residents of the place. I just can't take my phone. I can put my phone and I can collect the GIS data. I cannot do it. It's illegal. I need the permission of the owner of that residence in order to allow me to take the GIS coordinates. At least back in the US, I don't know here. That's very important because it's private information, which I can't share with others. Okay? But it helps me map in order to make a decision. Next is timeline. What was the time of the date of the disease onset? Like, in other words, we are targeting where is it likely that the index case emerged? What is the time frame that relates to it? That's what we start looking at, especially in the beginning of an index case, and then how the subsequent outbreaks took place. Next is mode of transmission. The shape of an epicode can indicate the following modes of transmission. All experts on this. Point source, all cases who are exposed at the same time. Continuous transmission, ongoing source of infection is occurring. That if I see a graph like this being generated for me, I know the infection is going on. I don't see an end to the process. But then when I see waves of these curves emerge over a period of time, that means it is propagated. It is person to person being transmitted. Last example would be COVID, which is clearly defines secondary cases. So step 6, develop a hypothesis. So a hypothesis, a theory about the source, agent, or a key feature of an outbreak. A hypothesis can be derived from the subject matter knowledge, known sources, vehicles, transmission modes, review of descriptive epidemiology, what would account the most or where. Now let's go back to the case outbreak that I was discussing earlier. So what did we do? We suspected Baba's Dairy Farm in Berks County, which had the license to sell raw milk. So we went to the farm, we sampled individual cows, 63 cows, 252 milk samples, bulk tank samples from 5 separate samples, fecal samples from 63 cows, environmental swabs from drains, alleys, driveways, and feedways. And we found 3 cows positive for Campylobacter, 2 out of 63. All tank was negative. Environmental alleys were positive for Campylobacter. DNA fingerprint analysis were identical from those of patients, cow feces, alley, and goats. So here we are able to tie the picture together and say the 3 cows were responsible for the majority of the outbreaks. The vehicle was raw milk, and the behavior that was associated was consumption. Okay? So we can tie those aspects together. It's a behavioral induced outbreak by consumption of raw milk in Berks County, by the milk sold by Baba's Farm on so and so. Now, questionnaire. When we develop a questionnaire, we gather data in order to test the hypothesis. What are the types of variables? Identifying information, That can be a GIS location you have point, demographic information, clinical information collected from hospitals, risk factors, whether they consume raw milk, behavior, or any other aspect, respondent information, if it's different from a case. Person may have consumed raw milk, but may not have shown clinical signs, but we still need to collect the data from those. And finally, the contact information, especially if you want to do tracebacks on these cases. Okay. And how do we evaluate the hypothesis? Typically using a cohort or a risk ratio study or a case control. Most of the time we tend to use case control studies. Okay. So the next step, the eighth step, is to refine, reconsider hypotheses, reconcile with environmental and lab results. And we may conduct additional environmental studies, laboratory-based studies. If the analytic study provides strong evidence of an association between exposure and the outbreak, don't wait for any positive samples. People are under the things is, let us see when the outbreak goes back before implementing prevention measures. If you see there's something, implement proven preventive measures like then, there, etc. Next is step 9. Implement control or prevent measures and evaluate. Review existing control measures to ensure proper use. For example, on farms that sell raw milk, their coliform count should be less than 10. They need to use chlorine in these different places and keep a record of it. Okay? So we go through all of that data as a part of quality assurance that this person meets the expectations to produce raw milk. The utensils that are used are sanitized or sterilized in the milk is stored. Measures that may be targeted one or more, eliminate the source. Now, in this case, the 3 cows that were positive for Campylobacter were taken away and put on the pasture. They were not with the rest of the cows. Interrupt transmission. That's what we did. We knew these were the sources of Campylobacter. Heady shedders, 10⁴ to 10⁶ per gram of feces. We took them away. And the process reduced the susceptibility. Although Campylobacter was still in the environment, we reduced the likelihood of it being recontaminated over a period. Right? Work with regulators, industry, health educators, and institutes for control measures because it's a public health issue. Create mechanism to evaluate both short and long-term effectiveness of control and prevention measures. So if we see another case of an outbreak of Campylobacter, we know where do we look. We need to look for the sources, most likely the lactating dairy cows. Okay. Step 10, communicate findings. Okay. Summarize investigation, make recommendations, disseminate the report, communicate the findings back to the healthcare providers and other parties. Let's watch this same, again, it's from the same group. Let's watch this video. They've done it. Oops. That maybe. Yeah, there. Yes. Oh, it's what it's positive.
Try.
Hey, any questions? Outbreak investigation, surveillance, anything you have? Yeah. Can you repeat that? So generally when we see amplified determinants environment, so it is already applied to an environmental source. When people source, it may be people source from another bird on the farm or some other sources. But the best way is to remove those cows because they are the ones that are contributing. And I mentioned the word 10 raised to 4 to 10 raised to 6 sample back for granite pieces. And if you're throwing 50 pounds of pieces down every day, you can imagine the amount of sample that would be inside of that. They could be e-coms, or more likely this is, these were, if I recollect, these were already in the second, third batch. So it was acquired on the farm, probably to other fecal routes, other processes, contaminated food could be one of the sources. Like birds could have come And usually we tend to see in many of these farms, the birds come and peck on the feed. They eat away the corn and also defecate it up. So so there are different pathways, but it is not confirmed. We can only say at this point in time, different pathways that most likely it is either contaminated feed or water with fecal. That's the likely source of this. We cannot go into that detail. All that we could do is just speculate.
So is there any difference between all this already or
So if it is already known, it becomes very easy to quickly implement network programs. So the ones that we are seeing that there is a propagated outbreak taking place, one way off a way, usually we should be able to identify the positive agent by the end of the second incubation period. I mean, the techniques are so good nowadays that are available within the second incubation period. So if the incubation period is between 10 to 12 days, and we are not able to identify in the first incubation phase, we should be ready to identify it in the second phase. Okay, where if you get a sample that comes in, especially if it's a viral one, becomes very difficult. If it's a bacterial pathogen, tends to be a little bit more easier to cultivate and grow. Where if it is a viral, it's largely unknown at that point in time, unless and until you largely suspect it to be a West Nile virus or a COVID-19 or an influenza. But it's always better to follow up. But by the end of the second incubation period, we're able to pick up even numbers, if that's the question you're asking. In fact, let's go back to 2003. It took us 3 weeks to identify the first SARS virus. Within 3 weeks, they were able to do the whole genome sequencing in 3 different places. I think in South Korea, Japan, and Canada, who were most affected by the process. In 3 weeks, the whole sequence was.
Epidemiology
Yes.
Only understood.
Yes.
What exactly means
So the transmission cycles. So many of the transmission cycles may be hidden, unknown at that point in time.
this was
Yeah, you're right. So you're absolutely right. We know that the camels serve as reservoirs. Now, where did the camels get it from? We have no idea. So when we trace the MERS virus, again, it goes back to bats at some point in time, but there is nothing like a 100% homologic comparison available. There are fragments that we tend to see in the MERS virus, very similar to other coronaviruses. So there are shared entities of the genome between the two viruses, but there's no way we can go back and say we're doing an evolutionary tree, reverse evolutionary tree going back in time. How many years ago, 10,000 years, a million years ago, when did this transfer from the bats to camels? Or was it very recent? We are unable to prove it, but we suspect coronaviruses tend to occur largely from the wild into human populations or domestic animal populations.
we have several regulations as far as
Yes,
all of this
and yeah, and as we go along, we learn. Yeah. Mhm.
It's for the
Yes, so go ahead. Okay,
Even I was not blind. When we get my knowledge,
okay, okay, okay.
nice talk. So the team was composed of people from the department. Nobody was not knowing anything what should be done. They were not prepared at all. And this is actually two things. Just wanted to admit here.
Yeah.
So these are limitations. Lacking knowledge means team has been designated. People are not expert. I was the only person who was having a microbiology background,
Right, right.
but my head, he was from totally different background.
Yeah. Yeah.
Like
So
science,
you,
what type of, who we should have, what questions we should ask. I just feel
Yes.
this thing, points.
you're right. It's the team is very important. It's absolutely important to have a person who is able to lead the team. He does not necessarily need to be a subject matter expert. He should be either a good clinician or a good epidemiologist, somebody who knows how to process an outbreak, how to delegate, how to collect the information. Because nowadays the systems are so standardized, at least for us. If I say that there's an outbreak taking place in a farm in Pennsylvania and they ask me to go and be a part of a team, I will first pull up the info format and keep it ready with me. And then I'll start looking into the clinical history. The first thing is the clinical history we start playing around. So once we know the clinical history, then I know what kind of team I need. If it is arthropod-1 viral things, then I need an entomologist to treat them. I definitely need. So it depends how you would like to move it. If there is multiple different foods involved, I'll have a food safety expert with me. So as the team leader, I have the ability to pick and choose whom I think would be able to contribute towards it. But I need to have a sense, what direction am I moving into? Or you can just go and start an investigation and then add on people at a later stage.
क्या कर रहे हैं?
Programs which are under surveillance.
Yes. You're right. Yep, yep. Yeah.
There is any new disease investigated. So what tools do basically use for its conservation?
So-
Mainly conservation?
Generally, what we do is we go based on the clinical findings, case reports in a hospital. What are the physicians seeing? For example, let's go back to your leptospira. Anything like flu-like related symptoms, but 104 with icterus, temperature and blood in the urine or deficiency in the kidneys would be one of the concerns is either it's an E. coli or a leptospira. That's the first thing hits me right from. And then we start looking into the processes both ways, both for E. coli and leptospira. And once we had a sample, either a urine sample or an environmental sample, we either, the way we generally do is we have a panel for antibodies, known confirmed antibodies sitting in the lab. So we test it against, we run it on a 96 microtetra plate to pick up majority of the pathogens what's there in pure culture or crude culture, whatever it is. If something lights up positive, we then start moving into those directions. Otherwise, for me, it's a no-brainer. I don't use serology anymore for the last 5 years. I don't use. I get a sample. It may be a sputum sample or a fecal sample. I run a metagenome on it. And in 4 days, it takes me 4 days, but I should be able to know what the signatures are. What am I really looking for? We started finding cases of koala virus in a set of koalas that had died in a zoo. We had never seen koala virus. It's a respiratory virus which was killing these koalas. And we were able to pick it up on metagenome sequencing. So we were lucky. First is we were able to, it's like a needle in a haystack, but we were able to pick it up. We did not get the entire virus, but there were signatures of that virus very rampantly present in all of the samples that we had picked. So that's a high level of agreement in the length of the sequence. For example, if I have a sequence length of close to 250 base pairs, I need to have a 99% match in that. I can't take a 36 base fragment and say, oh, it matches 100%, so therefore that's the virus. No, it doesn't happen. It largely requires larger segments of DNA, larger segments of DNA and RNA, and see what is the level of match and how many of them am I getting in order to have my level of confidence boosted up enough to say, this is the koala virus. And generally what we do is we make a decision, we don't confirm, we actually send it out to another reference lab to confirm our genome sequences. So it's a two-way street. It's just not I'm making the decision, the state health department may do it or some other diagnostic lab may do it. So even with unknown samples, our best approach today is going through the traditional routes by screening for different, for example, how did they find the West Nile virus? They made a mistake. CDC made a major error. When the first West Nile outbreak started taking place in the Bronx Zoo, where Tracy McNamara, who was the veterinarian and the pathologist, she started seeing dead birds all across the zoo. She looked at it, she opened up, she saw petechial hemorrhages, she saw all of the lung lesions. She called up CDC and said, I'm finding something of an hemorrhagic fever here. They said, send us the sample. So they sent the sample to CDC and CDC came back and said, oh, it is St. Louis encephalitis. Don't worry, it's endemic for the area. She was not convinced. She further went behind them and said, check again, check again. And they came back and said, it's West Nile. It was the first time we ever detected West Nile. Of course, CDC did it, but they used the panel of anti-sera that we have. And the anti-sera that lighted up positive with West Nile, it was cross-reacting. So that took us additional time to really figure out and say, this is not St. Louis, but it's West Nile. So every diagnostic lab, or what we call as a reference lab, has got these unique methods in place in order to identify a pathogen that cannot be recognized at a local laboratory. But generally, these reference labs, maybe a state reference lab or national reference or international reference lab, have the capability of identifying the unknowns within that given set of organisms.
How many numbers will be made?
It depends on the case. For example, if it is going to be Ebola virus, even one case is an outbreak. For example, in measles, 2 cases of measles is an outbreak because everybody is vaccinated. Why should it occur, right? So it depends. It depends where you set the lower level and where you set the higher level. It's like when you draw the standard deviation, one standard deviation above, up and below, is those lines. You need to work within those lines. If any of your numbers fall outside those 2 lines, I'm just using standard deviation or 1 as a measure, but if you have the numbers that flow across, and if it crosses beyond those 2 lines, you know that there's something wrong. Yes, we take morbidity data, tends to be better than mortality data, because mortality means it's very obvious. In birds, you go to a farm and you see significant mortality occurring, and based on the observations, most likely it's avian influenza. Most likely. But I'm not going to tell the owner it's avian influenza. I will pull the sample out, take it back into my truck, and I have my MinION set up on my computer. I will throw my samples in and I'll start making phone calls. And I will ask the police to come and wait in front of the entrance of the farm. They're not allowed to take anything out and bring anything in. And once it is confirmed, then I send the sample to the state lab. The state lab confirms it. And then we bring in what we call as people who do the culling. So the culling, in case of avian influenza, we use foamers. We use foaming substances. Carbon dioxide foam is filled across the flock. 250,000 birds. The entire farm is foam, and the birds die of suffocation in the process. And what do? We allow the birds to stay there. We dig a pit outside, collect all the birds from there and put it in it and cover it up. So we don't even try to move the birds outside the premises of the farm. We contain it within the given premises. So those are through experience and losses done in the past we have encountered. We have come up with a logical process of addressing, although we were very badly hit with avian influenza this time, but we did our best to minimize the losses. We think we lost close to 2 million birds just in Pennsylvania, just 2 million birds. Anybody else? Somebody had another question?
Especially care to be taken while notified with this.
Yes, PPE. PPE is absolutely essential. If it is a notifiable disease, you suspect it, you've got to go in with the proper PPE. Simple things like a face mask, glasses, and keeping the safe distance of 6 feet, talking to the individual is the recommended way of doing, even if it's a case of TB. Yes, you have to keep monitoring it. Yes. Mhm. Yep. You need to keep monitoring for it. Okay, so shall we take the next lecture up, the last one in the series, or would you like to do it after lunch? Let's take a poll. So Udya काही नाही करणार ना. नाही, उद्या नाही करणार. I do it now or in the afternoon. हाँ? कल तो कुछ नहीं है. This is the last lecture. Tomorrow the process is question answers. If you have question answers, I will sit with you, go through it. And after 11:30, what we will do is we will ask anybody who wants 30-minute meetings. They have a research project. They would like to look at the study design. They would have some data sets that you would need to look at it. I'm happy to look at it. Again, assuming that there are people who are interested. So we'll have 30-minute slots for people in class and online so that we have a better understanding or exchange of ideas. And many a times people that are online are hesitant to ask questions. So that may be another opportunity for them to sit and talk with me one-on-one in the process.
So we'll
We'll continue.
Yes, yes.
Okay, let's finish it up. Let's close this.
Answer you guys.
आपली सर्व करून हार्ड कॉपी म्हणून
Okay, the last of the lectures will look at how to model for diseases. So when we look at modeling for diseases, this is not something new. People have been doing this for a very long time, playing around with these numbers. So let's try and understand in terms of infectious disease modeling. So what we will do in this lecture today is I will provide you with a historical background, how disease modeling started. And then we'll talk about the importance. We'll then talk about the different kind of models, the stochastic models or the deterministic models. And then we will focus on the comparative. When we talk about deterministic, that's where I'll spend most of my time. We'll talk about the compartments, disease models, and we'll talk about what assumptions are used in order to construct the model. And then we'll touch upon the three different models, but I'll spend an exhaustive amount of time talking about the SIR model. So any questions here? Everybody okay? Okay, so let's move on with the next one. We'll talk about, as I mentioned, we'll compute the model, and then we'll also use a numerical example to follow it up. So when we look at the concept of disease modeling, Daniel Bernoulli, don't mistake his name. There's another Bernoulli who looked at physics. He was a physician who looked at pressures between vacuums. So this is a guy who was a mathematician and a physicist too. Okay? And he developed a method to calculate the gain in life in the event if smallpox was eradicated. So his mindset was a little different. He said, okay, in case if I eradicate smallpox, people are dying at the ages between 16 and 25. if I remove, what would be the life expectancy beyond the age of? So that was his modus operandi of looking at how disease modeling took place. But the real, I would say, the turning of event took place in 1911 when Ronald Ross developed a differential equation model for malaria as the perspective. So we'll be using a little bit of differential equations in order to set up our model. We used the first deterministic model or deterministic differential equation model for malaria by dividing the human population into two populations. One is the susceptible, another is the ones that are infected. With the infected cases returning to become susceptible again on the SIS structure. So susceptible, you become infected, and then you go back and become susceptible. Okay? So that's the concept on which he developed. So it was not a great idea, it's a simple approach. But when we come to these two individuals, Kermack and McKendrick, they took the Ross's model and then developed the thresholds or the assumptions that we use to develop the SIM. So what is the value of doing disease modeling? The first one is it provides estimates of the population risk. What population is at risk? Next, it tells us the spatial distribution and the spread of the disease. How is it occurring? It then tells us the effective or alternate strategies to control the infection or prevent the outbreak or a disease investigation. If you're doing a disease investigation, one is immunization programs. Are immunization programs working? Will it work as an intervention strategy? Are there any disease eradication systems that we can utilize? Another is the dynamics of the ecosystems. We know many of the diseases have their origins in ecosystems, especially environmental ecosystems. How do we address them? And the last part is decision making. That's where when I develop a model and I give it and tell the health administrators, I think this is if we are not prepared, how many billions of dollars are we going to lose another round? Okay? So these are some of the things that disease modeling has become very effective, is now effectively used by health administrators to make decisions. Okay? So when we look at the two different types of disease models, one is called as deterministic versus stochastic models. So when we talk about a stochastic model, it possesses some inherent randomness. Within the given agent itself, there is randomness. For example, looking at mycoplasma, may express surface proteins A, B, and F. Okay, so inherent variations is a part of the stochastic model. Possesses some randomness. The set parameters of values and initial conditions will lead to an ensemble of different outputs. For example, if the input is X, the outputs can be anywhere from Y1 to Y3. Thank you. So that's how it is. The next is the deterministic model, where the output of the model is fully determined by parametric values and their initial conditions. In other words, it is based on our assumptions, what assumptions that we apply in order to do a deterministic model. Now, a deterministic model, the input is X and the output is generally Y. Of course, we can take the Y and then create variants of this output, but generally we go with the concept, we use Y as an entity by itself to make the next subsequent set of decisions. So let's talk about stochastic networks. The term stochastic is used in many different fields, particularly where random processes are used to represent systems that seem to change in a random way. You're trying to do a computation where there is rainfall, there is temperature, and there is the mosquito population. So when you start doing those things, each one of them have their own inherent randomness. How do we account for it? So in these cases, stochastic models tend to work better. Okay? So stochastic models has a long history in biology. However, in the last 15 years, people have started liking it more and more because they have started appreciating what all it's able to provide us. It relies on an individual chance variation in risk exposures, disease, and other factors. For example, I may like to eat a raw egg in milk every day in the morning, as my mother did it when I was 5 years old. I'm 60 years old and I still do the same. So this is a behavioral factor, right? Whether the egg is contaminated with salmonella, whether the milk is contaminated with salmonella, and whether my habit is considered as a risky behavior. Okay? So those are some of the individual chance variations that we put in the process. It can be laborious and need many simulations to use or to obtain useful predictions. In other words, we have Markov chain model where we can take the same data and remodel it over and again to see if it falls into a certain pattern. Okay? So for example, when I do disease modeling and for using stochastic models, well, there are specific softwares that are available in order to do the stochastic modeling, and happy to talk to you guys if you're interested in that. Okay? So let me go back. I said malaria. Malaria can be an example, stochastic modeling as to the dynamics of the waves of different mosquito populations are going to emerge that are positive if the rainfall is so much, the temperature is so much, and the population of the mosquito load is so much. It is able to determine those aspects. Okay? We can make it even more complicated. We can look at the immune status of the population that is at the risk of being exposed to those mosquitoes. So you can add many different things. The more you add, the more variables, outputs will be many different types. And the reliabilities tend to fall away if you increase many of these variables into the process. It is more important to keep them rather focused and then study it. And if you find success with it, you keep on expanding it till the model breaks down. It doesn't go beyond a certain point in time. Okay? So let's now focus on the deterministic or the compartment models. For example, what we'll be spending our time today is looking at the SIR model. So what do we mean by the word deterministic? The word deterministic signifies the predictions of these models are determined entirely by initial conditions. What are the initial conditions that we find? What are the underlying equations that we employ? And more importantly, what are our input parameters? Deterministic model is based on non-linear dynamics of infection spread in a population. In other words, the population under study is divided into compartments. The assumptions are made on the nature and time of the transfer from one compartment to another compartment. Okay? The rate of transfers between the compartment are mathematically expressed as derivatives with respect to time and the size of the compartments. Models are systems of differential equations. So here are the three most widely used. There's a variation of SEIR models. There are many of them, but I would not like to go into it. Let's focus on these three. The first one is the SIS model, which is susceptible, infected, and then susceptible again. The SIR model, where we assume that, I'll talk about the assumptions later, is where the susceptible population over time gets infected and they recover from the disease. That's the SIR model. The SEIR model includes the process of exposure. And we know very well for sure, exposure does not always relate into an outcome. So we need to be very clear. And that's where the complex nature of the SEIR model comes in at that point in time. So the choice of which compartments to include in a model depends on the characteristics of the disease being modeled and the purpose of the model. Why are we doing it? So with that, I will move on and talk about SIR models. Any questions? Because now I will start going into crunching some numbers. If you have any queries, I think let's clear it before we move on to the next level. Okay. Anything? Anyone? Anything you'd like to have a clarification on? Oops. So the SIR model. So we start off with the process of a population. If we take a population, everybody before the onset of the disease is susceptible. Okay. So when we use the word susceptible, they all are able to get the disease, but haven't fallen sick yet as of this point in time. We then have another compartment called as the infected that have the disease and are contagious. And the last group is what we call as the recovered group, in which they have recovered from the illness, and we assume that they are immune to the organism or the pathogen. So in other words, we took the population and then divided them into three compartments: the susceptible, the infected, and the recovered. Okay? So keep in mind, this is where most of the students in my class don't tend to do well. Is they tend to say, oh, these are assumptions. And I change my assumptions when I develop the model. So these are the assumptions that you need to keep in mind when we talk about an SIR model. The infection is relatively mild. Everyone recovers. Example, mumps, measles, and rubella, where the mortality rate is less than 0.01. So here we are using that as an example. There is permanent immunity. I don't agree with the term permanent immunity. It's long-term immunity is there. And the population is rather fixed in site and confined to a geographical area. Example, measles, mumps, and rubella, eventually everyone recovers. And the other thing that we need to do is when we write up these differential equations, we do not include births and deaths that are confined geographically. We don't include them in the process. Okay. So, for example, when we confine geographically, it can be a shopping mall, dormitory, stadium, school, or even a bigger city by itself we can take into consideration. Okay. So now let's go ahead and start computing our model. The first model that I would like to share with you here is the calculating the rate of change. Okay. What do we mean by rate of change? Is the rate or the change in the number of susceptible individuals over a period of time. For example, on the x-axis, we have time as the measurement. On the y-axis, we have the number of individuals who are susceptible. So at the start of the population, there is the entire population, almost the entire population is susceptible. But over time, they become infected and their numbers decline over a period of time. So therefore, the rate of change in the susceptible or the rate of time is understood as S prime, or the rate of change is measured by noting it as a change by S prime. Okay. The next is recovered. Again, when we start when we look at the model in terms of recovery, recovery is indicated in terms of time over the y-axis, and time is represented on the x-axis. And the rate of change is measured by change in recovery versus change in time. So initially, to begin with, when we come to know of a disease outbreak is ongoing on, by the time we detect, there are already people who are infected. Okay? It's not that they are zero in number. There are already people who are infected, but we have not figured them out yet. So that is why you'll see that the curve starts at a very low level, and when it expires, everybody at some point in time has recovered from it. Whereas the infected is nothing else but a reflection of the two, of the S prime and the R prime, that shows how the number of infected increase. And once it reaches a population threshold, it then starts declining because there is no more susceptible people left to get infected. Is everybody clear on this? Did everybody get this? So the question is, are the rates at which the compartments are changing, are they constant or not? Infection does not behave in a linear model. So keep that in mind. Okay? That's a trick question, and I tend to ask them. So now let's start computing the model as we go along. Okay? Let's calculate how to calculate S prime, how to calculate I prime and the R prime. The first thing we need to know is what is called as alpha. And alpha is nothing else but the rate of change from the susceptible to the infected. And S prime and beta is the rate of change from the infected to the recovered. In the process is how we move from one compartment to another compartment. Okay. Alpha indicates rate of change from susceptible to infected, and beta refers to the change from the infected to the recovered. And what is S prime? Minus alpha. Why minus? Why minus? Let's hear from that side. Why minus? Why minus? Any answer? Just blurt it out. Because the population is declining, right? So therefore, you have to have a negative association with it, right? So therefore, it is minus alpha. What is R? R is beta. And what is I prime? Alpha minus beta, right? Concept is very simple, but let's kind of expand on this a little bit more. Is everybody clear? Okay. Archana, are you good with this? Yeah. Okay, let's move on to a little bit more set of numbers. So let's talk about the rate of recovery. Okay, first we'll talk about beta, the recovery rate. And what's our assumption? Our assumption is everyone recovers. And 1% of the infected recover each day. Not everybody recovers at the same time. So that's where the rate of change we are calculating over time. How do these numbers change? The infection lasts for K days. Okay? It may be depending on the incubation period or the duration of the infection. It can be K days. For example, I've taken in this case 4 days. So it is 1 by K, 2 by K, 3 by K, and 4 by K. In other words, 1 divided by 4 is the value of K. So each day, 1 by K of the infected population recovers. And this is called as the recovery coefficient. And how do we calculate R prime? R prime, which we know is equivalent to beta, is nothing else but a multiplicative factor of 1 by K times I, the ones that are infected. And this particular complex, I by K, is indicated by B. In other words, B is the recovery coefficient and equal to 1 by K, or B is equal to 1 by K. So the formula for calculating the rate of change, or the R prime, is B times the number of people who are infected. Okay. I would like you guys to get this wrapped around. Very important, because before I move on, I'm going to throw in a few more numbers at you. Okay, of course, we'll work the problem out. We'll work a problem out. You want me to go back? Okay. So here, which one? R prime. R prime is the rate of change. The rate of change where it is taking place on that 1 by K day times the number of people who are infected. Okay, R prime is the rate of change you are measuring. Okay. So let me compute the next one, and then when you work out the model, you'll understand that a lot better. Okay. Or you still have some clarities here? I can wait. I got the entire day. Number of infected. So look at the process, what we are doing. We're trying to calculate beta, right? So forward, what do we need? We need to know how many people are infected on that given day. And that's why it is R prime. And the length of the duration of infection is 1 by K. Okay? So if it is for 10 days, it is 1 by 10, that means 0.1. Okay? Is that clear? Want me to move on? Okay. So now that we have understood how to calculate beta, let's try and calculate alpha. What is alpha? Alpha is the rate of transmission. The transmission rate varies jointly as the susceptible and the infected populations, as the infection depends on the interaction between the two groups. Okay, so S prime is what we call as alpha, is nothing else but A times susceptible times infected, where A is called as the transmission coefficient. Again, the word transmission, keep in mind, transmission will only occur if the exposure has taken place. Keep in mind, okay? So let's look up what are the components that make up the value A here. So here, the way we determine A is as follows. A susceptible person has a certain percentage, P as a decimal of coming up with contact with the disease. Doesn't mean, first there is a contact. What is the likelihood of developing the contact? That is determined by the variable or a percentage P. And if this contact is made, then there is a certain percentage of the people who have made the contact become ill with the disease. So the way we calculate S prime is equal to alpha, which is the rate of change or transmission coefficient, is A times the number of susceptible individuals and the number of infected individuals. In other words, it is P times Q times S times I. Okay, making it very difficult, but so very simple when you see the example. So S prime, what we call as the rate of change in the susceptible population, is calculated by first identifying what percentage of individuals came into contact with the disease and how many of them actually developed the disease times the people at that point in time that were susceptible and those that were infected. Okay? So here are the three ways of how we put this up. S prime is equal to minus P times Q times S, or minus A times S times I, and R prime is B times infected, beta times infected, and I is nothing else but the difference between the two compartments on either end. Okay, read this example very carefully and I will walk you through this. Or you want me to read it over for people who are there at the back? So let's look at an example of respiratory syncytial virus. The following example is fictitious. I don't want to be blamed by either the city or the people, so I've called it fictitious. Suppose the Twin Cities metro area, where I'm sure you'll be going to Minneapolis, hopefully at some point in time. Those are called as Twin Cities. The Twin Cities metro area, the population of 3.32 million, experiences an outbreak of a strain of respiratory syncytial virus that everyone eventually recovers after 10 days. Okay? And which grants lifelong immunity. Scratch the word lifelong, it says, say, extended immunity once recovered. When the epidemic was first detected, there were already 50,000 people that were infected, and that's seen in this box here. Okay, and 40,000 were already immune to the disease. That means they were infected and already had recovered when we first recognized the disease was taking place. Suppose, now these are the assumptions here. Suppose that a susceptible person has a 0.004% chance of contacting a member with the infected population. And if the contact occurs, 1 out of every 25 people will fall ill to RSV. Calculate the populations in the 3 compartments for day 0 and day 1. So what is the starting population on day 0? It starts with 3.2 million, 3.32 million, but the actual population of the city is 3.3 million. What did we do? We took away the 90,000 individuals who are either infected or susceptible. Okay, and these numbers come from these 2 boxes which I've indicated here. Is everybody clear on this? How did we get these numbers in these boxes? Okay, so let's go ahead and compute B. B is how much? 1 by K. the length of the duration of the disease is about 10 days, so it is 0.1. K is the number of days it takes to recover from the disease. And then let's go and compute A, which is P times Q, where we have found it to be 0.1, 2, 3, 4, 5, 6 zeros and a 16, where P is equal to 0.00004 times and Q is equal to 1 by 25. Why did I add these two more zeros here? It's a percentage. Very good. Excellent. Somebody is paying attention. So it's a percent. When we talk about 0.004%, when we linearize it, we add the two more zeros into it. Okay. So these are some of the common mistakes that if you're giving this problem to a student, they will overlook this and then start doing the calculations because they have forgotten the percentage aspect of it. Okay. So now that we know, let me go. We know what's the value of B. We know what's the value of A. Let's go and calculate the rate of change on day 0. So the rate of S prime, the way we calculate is 8 minus A times S times the susceptible times infected. That is A is equal to 6 zeros and 16 times 3.2 million, the starting population. As you recollect in the earlier chart, we took over 90,000 people, times 50,000, that is equal to minus 25,850. So does everybody get it? Here, 50,000 is the infected population on that time. Is this clear? Okay, let's move further. What about R? It's B times I, where it is 0.1 times 50,000, which is 5,000. Okay. So on day 0, in addition to the 50,000 that were already infected, their numbers have increased by 5,000. So what is the infected numbers? Are you able to appreciate this? Okay. So let's go ahead and calculate. Question. What are the populations of various compartments on day 1? Answer, when T is equal to 1, you have the population starting at 3.2 minus 25,000, which you have here. The population has reduced to 3.204 million. What is the number of I? You have increased it by 50,000, the original, plus the 20 that we were able to calculate here. So on day 1, the population of infected people has grown to 70,000. What about the number of people who are recovered? It's 45, because initially we started off with 40,000 and then we added 5 more thousand people to it. Okay. Now, you all will go and calculate by hand what happens on the 25th day. Are you ready? Don't worry, I'm not going to torture you. So I've created an Excel sheet where you can actually go and compute these numbers. Okay. We can do this for 2 months. So let's see if I can bring up. So here, I have all of the equations that I need in order to construct the model. So what do I do? I've already computed these numbers for day 0 and day 1. Now that I do is watch the change in this graph. See that? What's happening? By 30th day, there is still you see this line where it comes down and touches the baseline? There's nobody left to be infected anymore. So this is how we can compute the model. So I've also, when I go back, I'll send you my slides and also I'll send you the Excel sheet. Some of you may already have it already. So this is the Excel model that I generally use this in the class to show how effectively we can construct an SIR model. Any questions?
Probability of following the same equation, as you said, it is not a linear one.
It's not linear.
Which is the probability? Follow the same one.
So I didn't understand your question.
Sometimes because so many models have been developed within the program. Sometimes it's
I'm only specifically talking about SIR models, I'm not talking about other models. You're confused. I can see from your eyes. You're blinking. You are blinking. I think I have a long time with you today. What's it? This is only for infectious diseases, and also very important, I've used a set of assumptions. If I change my assumptions, the model will take a different shape. Yeah, and this is largely, I do it for the students to understand how the model operates. We can do many different assumptions and change the model. But this is a very basic model. You should understand the concept, how populations move within the compartments. How do we calculate those compartments? And when do we anticipate? Because if I go and look at a curve, when does it, oops. For example, if I were to be looking at this graph, one of the things that I would like to know is when is it the infection will peak? It is going to peak somewhere around 10th, 11th, and the 12th day. So it gives me an idea. Right at the very second day, I'm able to compute it. This is the assumptions that are going to work. By the 10th day, I should see the entire population peak at some point in terms infected. When will I see the number of susceptibles almost non-existent? Somewhere around 25 to 8. So what's it? That's the model. That's where we can put in another model. We can use an SEIR. Okay? We can make variants of these models. How you would like to do it, it's up to you, but that's beyond the scope of this group. Because you need to appreciate this and do the modeling yourself first before I throw in some more additional things as to how do I make variations in recovery. And I can make it chronic recovery. I can make so many different. But you need to appreciate this. Do it by yourself, so that you are understanding what is alpha, what is B, what is A, what is B, what is the probability of exposure, what is the probability of infection. So with that. We go back. So another thing that we do is determining the threshold of infection. So as if you are in charge of a hospital or a given taluka or a given district, the first question is asked is, when is this disease going to peak? You know, that is very important for us. When is it going to peak? I don't want people to suffer. So the number of susceptible population for infection rate to be 0, again, susceptible population to be 0 is changing from a positive infection rate to a negative infection rate. The way we calculate this is nothing else but B divided by A, which is 625,000. So once the population reaches 625,000, that's the time when the shift of the curve takes place, where fewer and fewer people will start becoming susceptible to the infection. Okay, so keep this in mind. This is the question people will ask. When do you think we are going to start seeing the decline in infection? This is the way to calculate it.
when the infected population is 6 lakh.
Yes, it's 6 lakhs. Yes. Yep. So quarantine. That's where we as public health people come in. Says, guys, fine. It takes 10 days. Is there any way we can look at controlling the infection? So let's use the word quarantine. The goal is to significantly slow or stop the spread of the disease where the I prime is less than 0. Okay. Keep in mind, suppose a quarantine was put in place into effect on day 0. reduce the chance of contracting the disease by a factor of 20. Nobody goes out of the house for X number of days. That helps us reduce the spread of the disease by a factor of 20. Was it effective in stopping or slowing the spread of the disease? So how do we compute this? We compute this by looking at the value A, the value B, the S prime at the start of the population, the S, the I, and the R, and then we utilize the factor 20. When we multiply these numbers, it shows that it becomes minus 3,708. In the process, yes, the disease is slowing down. Okay. You get it? We divided the value A by a factor of 20. That came out to be the 8 zeros and 8 times 3.2 million. That was on day 0 times 50,000 times minus 0.1 times 50 is equal to minus 3,700. Okay. So in other words, yes, the disease is slowing. So next comes this is a trick question everybody asks, a reproductive number. It varies from disease to disease. In fact, people have, their entire life, all that they work is on reproductive number. If you're an epidemiologist, you've done your PhD and your postdoc, everything is on the reproductive number. So this is just a glimpse of what a reproductive number is. Now, so let's begin to understand what do we mean by R0. R0 number of cases directly generated by one infectious disease case in a population where all the individuals are susceptible to infection. Okay. The average number of individuals directly infected by one infectious case during his or her entire infectious period. And in a population, if R0 is greater than 1, keep this in concept, we have already talked about it earlier, is greater than 1, there is an epidemic that's going on, and the disease occurs in the absence of intervention. Okay? If the R is equal to 1, that means it's an endemic stage. Disease occurs, goes away, comes back again, but in smaller numbers. The next is R0 is less than 1, and that's what we all are focusing or attempting to do here, is successful control of infection, or the disease by itself naturally dies out. Okay? Now here are a set of R0 values that have already been calculated. For example, for one infectious individual, if we assume for measles, which is airborne, that particular individual is most likely to transmit the disease to another 12 to 18 people. So that becomes very much of value for us to compute it in the disease models. Okay? Whereas there are certain diseases where influenza, its R0 is, although it's highly transmissible, it's just 2 to 3 people. Okay? So Ebola, it's 1.5 to 2.5. MERS, 0.3 to 0.8. Okay. So let's go and talk about the basic reproductive number. How do we generate this number? You will ask me the question, where does this number come from? Now, the way we do it is we require 3 sets of values. The first set of value is number of contacts that occur per day. And if we look at it is a point where we can actually do the intervention, like quarantine. By doing quarantine, we prevent the number of contacts that occur per day. Transmission probability per contact, we can still modify it by wearing masks. Okay. And the duration of infectiousness, if you're vaccinated or if there are medications available to reduce the duration of, for example, if you are undergoing, if you're likely to have flu, if you take Tamiflu, the duration of the illness will reduce over the period of time. So let's go and calculate the average number of contacts made by an infective individual during the infectious period. For example, the number of contacts per day, I've kept it constant. It is 2 persons per day. Likelihood of probability is the one that I had changed, ranging from 0.2 probability of contact to 160 probability of contact. And I've kept the number of days of infectiousness to be constant for the given disease. And when we look at the R0 changes. For example, for 2 persons per day, if there's a very small probability of 0.2 and times 5, 2 people will be infected. But if we increase the likelihood of probability to 20 probability of contact, it becomes 200 persons. And then when we say it is 160, you go into a mall, you're the only one who is infected. Forget it, rest is history. 1,600 people become infected. So again, these are numbers. These are not actual numbers, but gives you numbers for you to work around. Okay? See, let me go back. What's it? So that's a variable. What's the likelihood of becoming in, transmission of probability per contact? That means this we are calculating the value Q. Based on how much contact the person is having with uninfected people. So this is determined based on the population densities, based on the likelihood of contact. For example, if I'm going to be going to a school and the population rate is the likelihood of me coming in contact with people because I'm excluding myself is still there. So it is 0.2. But if you go to a large venue, there are many, many people, that's when we look at the numbers. Okay? Those numbers is largely dependent on the population exposure. Mhm. Yes. Right. So if you go back to the previous slide, if you go and compare COVID-19 and influenza, COVID-19 is 1.4 to 3.8, and influenza is anywhere 2 to 3. So the rates of infection that we tend to see is almost similar between avian influenza and COVID. Okay, so it is exposure to a population. That's what we are estimating at that point. It's an estimate. We come up with that estimate based on the population density and the nature of the disease. For example, these have been already calculated through previous exposures and previous disease outbreaks. They use those numbers to calculate the R0. Do you get it? This is based on previous disease outbreaks. But in the event you want to calculate, in the event you want to calculate for an unknown disease, you can put in your set of assumptions in order to construct it. So here, this is how the reproductive number really works. For example, oh, sorry. Okay, so when reproductive number is equal to 3, it's greater than 1, right? Are you able to see how the process moves? So let's assume when R0 is equal to 0.5. Less likely, okay? Because it's less than 1. So these are some of the benchmarks we typically use in order to calculate the R0s. So the R0 and threshold relationships. For example, smallpox, the R0 value is 5 to 7, herd immunity. That's what we are really looking at. Let's look at SARS-CoV-2. The R0 is 5.7, again, calculated by a different study. And in order to achieve a herd level immunity, we need close to 82% of the population to be vaccinated in order to decrease the threshold of infection. So this is utilized in order to calculate thresholds of immunity. Another way of looking at it. Thank you and Jai Hind. So done my job, ready for questions and answers. Yeah. So is anybody here to announce it?
Hello. What are the about the parasitic diseases? Mostly helminthic or blood protozoan diseases.
So there are diseases that
Because it involves intermediate host and other environment factors.
Malaria parasite. Malaria is also a parasite. Malaria. Malaria is also a parasite.
Which one?
Malaria. So the model for malaria will be SIR.
Because the R0 values are very big. By geniuses, the mortality rates are going to be very low unless it hits your brain at some point in time. Other than that, yes, long-term dietary medications and these chronic diseases are likely to happen. So for chronic diseases, we need to take it. So it depends on
Mortality, morbidity and mortality.
It depends on the disease, what kind of model is most appropriate.
So outside agent
Yes.
R0 may change.
For example, if the infectious agent is highly infectious, the models will change. If they, for example, smallpox, mortality rates can be up to 90%. Some of these models may not hold up. We'll have to make different set of assumptions when we include mortality as a part in the equation. Did I get your answers right, or are you looking for something different? All of the details are available on, all of the details are on. I'm trying to figure out the slide numbers, so give me a moment. So here, if you go to slide number 291, which says characteristics of a good screening test. So here we would like, if you're in the process of developing a screening test or a diagnostic test, the first and the foremost is the simplicity of the test. Let's say, for example, you have a choice of developing a lateral flow immunoassay. For that, you would like to know if the antigen is present in sufficient quantity to be detected. Do you have good quality antibodies, more preferably monoclonal antibodies? Next is rapid. How rapidly can you do the test in a matter of 10 minutes, 15 minutes, in order to give a very high level of sensitivity and specificity is one I would do. Another is it should be inexpensive in the sense there'll be a little bit cost on it, but it should be fairly inexpensive. So I can give you an example here. The biggest market for lateral flow devices that we tend to see is for detection of malaria. And the World Health Organization has contracted many companies, especially in South Korea, to develop these lateral flow assays. But the stipulation that the World Health Organization put was that every particular lateral flow immunoassay that is developed should cost less than 20 cents, because then only countries who are what we would say as developing or underdeveloped countries, where we tend to see higher cases of malaria, they will have the purchasing power. for those diagnostic assays, especially if I'm giving an example of malaria. Next is it should be safe to use. It should not contain really caustic chemicals or reagents in it. And hopefully LFIs don't allow you to that. Another is acceptable. How acceptable is the given assay that you have developed is going to be by the profession, either veterinarians or doctors, how easily they are going to accept it. That's one level. Another is how acceptable is it at the consumer level, especially if it is sold over the counter, or what we call as over the counter diagnostic assays, which is becoming more and more popular. For example, you can go and actually purchase kits to detect urinary tract infection, or you can utilize for looking at the presence of strep throat. So these are commonly available, especially in many of the developed countries, is over the counter. I don't even need to go to the pharmacist in the drugstore to request for those kind of diagnostic kits. So again, coming back to to slide number 291, gives you kind of an idea. If you are in the process of developing a diagnostic test, you should keep the following 6 things in mind. Okay. So next one is, looks like Neelam is behind me today. So, okay. So Neelam has another question. Also, can you clarify about the parameters important to consider for modeling for fluoroquinolones, or can we specifically go for enrofloxacin? So the genes that oversee the resistance to floxacin is typically gyrase A and gyrase B. That's what we typically look for. Now, irrespective, it will go for the class of the quinolones. You should be able to detect, but if there are variants, then it may become a little difficult. So as I would say, if you're looking for enrofloxacin, fluoroquinolones should be able to work for the same condition. I don't get your question here. You said, what parameters should I consider modeling for fluoroquinolones? Example, you said enrofloxacin. So I need to know what species are you going to be looking at? That's the first important thing. What is the frequency of use of this antimicrobial on the given farm? So those are some of the things we need in order to create the assumptions. So assume for us, we don't use fluoroquinolones in poultry, nor do we use it in dairy cattle, except for dairy cattle that are less than 30 months of age, because we don't want any residue-related issues in meat and milk. So I'm a little skeptical about saying a model without knowing much about the question. So feel free to expand upon your question, and I'll take another shot at it. So another question I have from her is, half-life is important as explained to you. Need to consider environment. Can we go from modeling considering multiple parameters, or just one is okay? Again, this is more confusing than the first question. So I would appreciate, why don't you do one thing, Neelam? Why don't we get together for half an hour tomorrow, and I'll do my best to walk you through. So one-on-one, I can come over the Zoom or whatever the linkage that we have developed here for the conference, and then answer your questions. So it's now becoming a one-way street, and I'm trying to interpret what you have written. It would be best, more justification would be there if I have a chance to interact with you one-on-one and try to understand your questions a lot more better. So the next one is, can you please clarify on meta-analysis? We really talked about doing meta-analysis. Maybe as a reference, I must have talked about meta-analysis. Yes, it is one of the forms of analysis that we typically apply using epidemiologic methods. And meta-analysis or systematic analysis or systematic review, what we call as, is looking at the cause and effect that has been already been established by many review papers. Let's say our friend here, his specialty is tick fever, and he's specifically focusing on using tick fever related to theileria and a given drug. He would like to see the efficacy of the given drug against theileria. and he has collected 150 papers. And now what he is going to do is he's going to read those papers, and then he is going to set a criteria. I need to have cattle who are above the age of 24 weeks of age, not more than so many weeks between this age group, this particular breed, and confirmed with hilaria and this treatment, and what are the outcomes. So he's specifically looking for a set of 5 or 6 clear definitions from the paper. If the paper is able to provide that information for him and the outcomes, he collates all of that data and analyzes it using appropriate statistical methods to see if all of the combined data together are giving us the same results or giving us different set of results. Okay, so that's what we call as meta-analysis. But more so, before doing meta-analysis, the first thing we typically tend to do is a systematic review. So the first thing we encourage all PhD students in the field of public health or epidemiology, if they are given the topic to work on, say, enterotoxigenic E. coli in dairy calves between the age group of 3 and 12 weeks of age. So he or she specifically goes and collects research publications through PubMed, and more importantly, just don't rely on PubMed. What else? What other sources will you do? Where else will you go? Google Scholars. What else? What else? What else? International dissertation abstracts, because many students write up the thesis but never write papers. So I have many examples of that. I don't want to go there, but that's what typically happens, is that the data stays in a thesis. It's good data. Don't mistake me. It's good data. Just the reason it's not published or a peer review, there's already been reviewed by a peer of scientists or professors in a given institution. So there is some level of credibility to that kind of data set. So I would encourage you to go to PubMed, ORCID, CAB abstracts, wherever you can find, but don't forget to go and look for international dissertation abstracts. Also, you need to be very careful. Many of the publications are in languages of the native country. You may have a very good thesis that may have a very short abstract in English, but the entire thesis is in Chinese. So you run into these kinds of problems. So whether when you set up the study, do you accept it? Or do you say we only picked up articles that were written in English or in any related languages that were utilized for the study. So it becomes very important how you set up your initial criteria for doing the systematic reviews. Why systematic reviews? Because it allows the students to get fully immersed in the topic that the person is going to work on. So invariably, systematic reviews, depending on the topic, can range anywhere from 30 publications to 300 publications. Okay, and it is very much on the student to virtually memorize all that's available before he comes to the thesis dissertation group and say, this is the study I propose. And every particular proposition or objective he creates, he has justification based on the systematic review that he has done. He says, calves after 12 weeks of age show a decline in antimicrobial resistance profiles. And that's true. And he has publications to support his data. And then he's able to also synthesize the data in the form of a table from 15 different papers and show how the decline has taken place. So that's where I would say is to utilize systematic reviews. And then when you become an expert doing systematic reviews, then you go and start doing meta-analysis. Maybe that's a long-winded answer to a rather short question. Yep. Yes. Okay, how did you do it? How did you do the meta? Okay, so he will be able. Okay. 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 Okay, great. I'd like to see it. Yeah, great. Excellent. Yeah. Yeah. Yeah, sure. Yeah, thank you. Okay, Neelam, the next question you have for me is also I want to know how Markov model is different from other models. So when I talk about Markov's model are simulation models, okay? You simulate the same data set over and over again using different conditions. And then you end up and say, where does the model come up in the form of a median or a mode form of observations? And then you recommend those. So if you want, I can refer you to a paper, or if you look at, I would recommend you to read the chapter on disease modeling, the infectious disease modeling book by Rothman is one of the best books to look for in terms of Markov chain modeling. He actually walks you through the steps. And in the future, if I'm supposed to be offering another course in epidemiology, I will cover Markov chain modeling and we will model it in class. So you had two chances. One is you can go and look in Rothman's, his book, or you can wait for me if I get called, or happy to share with you how to do the Markov chain model. It's very simple. It's very easy to do. It's not much. Again, everything is based on the set of assumptions, and I've been talking for morning, the set of assumptions that you employ in order to do your simulation assays. Okay? So the question, how we can apply it to food safety. Yeah, it's in fact, Markov chain models has been very widely used in food safety. For example, you have a pathogen. Let's say you're working in Escherichia coli 157H7, and we know it is available in, maybe not available, it's quite frequently isolated from leafy vegetables, especially in the US. And you would like to have different exposures to UV light and see the levels of contamination. So you can model for looking at decontamination of E. coli 157H7 under different UV conditions using Markov chain modeling, and which of those parameters would work best. What is the duration of exposure? What is the amount of spinach or green vegetables that you're being exposed? What is the height between the UV lamp and the given food product? So those are some of the things that we can manipulate and then see if the outcomes that we are looking for is the base model is you're looking for a 4 to 5 reduction, log reduction in the original numbers. Is that what you would like to achieve? And changing the UV lamp, changing the height, exposure, and time, does it allow you to achieve a 3 to 4, I would say 4 to 5 reduction, log reduction in E. coli? And if your model says, yes, it is able to do it, then you go and experimentally prove it, whether you can do it. So that's where in food science, especially in food safety part of it, they have extensively used Markov chain modeling to study destruction of foodborne pathogens. So you have another question, how do I choose models for my own research study? I wish I had known your research study, then I would probably able to kind of make a suggestion. So here I can't comment much, Neelam. Perhaps you said you indicated that you'd like to meet with me tomorrow. Happy to do that. Please repeat the book for Markov's model. You can look for Epidemiology of Infectious Diseases by Rothman, Rothman. It's an excellent book. I would highly recommend if you are going to be in the business of disease modeling and epidemiology. So the next question is, do we need lab settings while we are working on models, or survey instruments will do. It depends on the nature of the study you plan to do, whether it's lab-based or it's going to be a survey-based or a combination of both. Your ultimate goal is to have quality data for it to be modeled. If you don't have it, then that's a different story. So I would kind of stay focused on what kind of data you're generating and what you would like to end up doing with it. So that's my suggestion. Again, I'm a bit confused with the question here. I'm slow in mathematic understanding. Will you please provide us an Excel sheet also to refer? Yes, Neelam, so by the end of this day, I will upload my today's PowerPoint presentation and the Excel sheet that I used, and I showed you how to create the SIR model. I'll be sharing that with you later this evening. Again, another one from Neelam. Also, please let me know. Can we ask for any doubt afterwards, either through mail or call? Yes, you're most welcome. This is like the process. Once you're in touch with me, you're in touch with me forever. So feel free to get in touch with me, email me. Happy to exchange emails and talk to you over some of your questions that you may have. Dr. Deepthi Vijay says voice is not audible. Our serious apologies. At 2:18, our system shut down, and I'm working on an alternate system that has been very kindly set up for us by the group here. So that's all I have here. So Neelam, I need to sit and talk to you tomorrow in order to help you out with some of your questions. So there's only one. So with that, I think I will stop here for the day. If there's anything else, more than happy to join you all tomorrow at 10 o'clock. We can start the discussion process again and say for about an hour, hour and a half, and then we can set up time slots, put it in the chat box when you would like to have a chat with me, or we can actually visually see each other and then ask questions and go from there. Okay. Thank you once again, and it was a real pleasure working with you all, and look forward for the closing session tomorrow. Again, it's ad lib. There's no agenda for tomorrow. I finished all my teaching requirements. It's just trying to understand you and trying to be an enrichment process for me too. So with that, I'll stop here and have a nice day. Bye-bye.